Dr.Sreera Pani Gopaluni sir, the first speaker, who is going to be talking on basics of transplant immunology. Please come on to the dais.
Yes, ma'am. Ma'am, I please invite Dr. Anuradha ma'am, a consultant of KIMS Sunshine, and Dr. Manjusha ma'am, HOD Department of Nephrology, Gandhi Medical College. Please come on to the stage, ma'am.
Good morning, everyone. Welcome to this immunology workshop. We nephrologists are now doing more and more transplants and more difficult transplants. So, where immunology is very, very important, and we as nephrologists are not as well trained in immunology as immunologists are. So, we are happy we have a host of immunologists today speaking to us about various aspects of immunology. And to get the ball rolling, we have Dr.Sreera Pani Gopaluni, who is a consultant nephrologist and transplant physician at the Citizen Hospital, Hyderabad. He did his PhD from the prestigious University of Cambridge in autoimmune diseases. He worked internationally renowned centers such as Leeds, Oxford, and Cambridge. He is a member of the review editorial board of a reputed international immunology journal, and is a peer reviewer of multiple journals such as CJSN, Kidney International, BMJ, and Annals of Rheumatic Diseases. He has over 45 publications, and his interest is on immunology in transplant. And it's my pleasure to welcome Dr. Sreera Pani to open the innings. Dr. Sreera Pani, please.
Good morning, everyone. Thank you for that introduction, ma'am. So I've been asked to discuss about the basics of transplant immunology, such that subsequent lectures will be a little bit easier for you to understand. And this is my privilege to talk in front of such an august audience here. So if anyone is wondering what this background is, particular protein, or displays some other abnormal protein, then it knows, okay, there is some sort of foreign antigen here and I need to get activated. So let's try and deconstruct the earlier problem where this patient developed acute T-cell mediated rejection on day 30. So here we have this HLA phenotype of these patients. So as you can see, I have demonstrated 3 HLA molecules with 2 alleles per each. So the first column is A, second one is the second allele of HLA class A, and then subsequently demonstrated B and DRB. So what you can identify is those in these pink boxes are different between the donor and the recipient. So these are the molecules that the immune system tries and recognizes as foreign, and it doesn't like it. And in the setting of an organ transplantation, the HLA antigens are the most robust antigens that can incite an allo response. Okay, so there are so many proteins that are available, but it is these HLA molecules which the immune system does not like and will identify them as foreign. So what are these actual molecules? The major histocompatibility complex. So this system is present in all mammalians. In the humans, is also referred to as human leukocyte antigens, because these are for various reasons it's been named as such. These are present on every nucleated cell that is present in the body. Okay, but there are 2 distinct subtypes of HLA molecules called class 1 and class 2. Okay, they are different in their what you call the protein structure. In class 1 you have 3 alpha chains and 1 beta chain, and in class 2 you have 2 alpha chains and 2 beta chains. That's not important. What is important is the presence of these antigens on different subsets of cells. So HLA class 1, this is present on every cell. HLA class 2 is only present on antigen presenting cells. Okay, so going into the genomics of this, I mean there are 6 loci and in total, and each loci has got 2 alleles, so in total there are 12 alleles. But we typically do HLA A, B, and DR phenotyping because they were considered at one point to be the most important antigens that incite an allo response. But increasingly we know that DQ and DQ is also important in causing antibody mediated rejection. So a particular patient gets these alleles, one set from the father and one set from the mother. Okay, this is universal. There is no cross. There is no discrepancies here. So what's the actual purpose of having these HLA molecules? I mean, the chance occurrence of someone having an organ transplantation is so remote. The immune system is not designed, or this HLA system is not designed to reject the organs. Okay, there is another primary purpose for these HLA molecules, and what is that? That is to present the peptides, either endogenous or exogenous. These are primarily derived from pathogens to the immune system. And here, class 1 molecules, A, B, and C, typically present endogenous antigens. So these are the proteins which are broken down within the cell cytoplasm and are presented on the MHC class 1 molecule. So like viruses, for example, when they infect the cell, they become endogenous, and these are presented on the class 1 molecules. And class 1 molecules are primarily recognized just by CD8 or cytotoxic T cells. As opposed to class 2 molecules, these are present on cells called antigen presenting cells. So there are 3 types of professional antigen presenting cells. One is called dendritic cell, the other one is macrophage, and the other one is B cell. So class 2 molecules are only present on these antigen presenting cells. So here, these cells phagocytose the exogenous protein material, like the bacteria, and then they break it down and then load them onto MHC class 2 molecules. And these are recognized by only CD4 T cells. So essentially, the MHC system is there to focus the T cells to identify the peptides in the context of self-MHC molecules, so that they are primed to sort of attack the foreign microorganism that is causing the trouble. So this image shows the interaction between the MHC molecule and the T cell. The T cell receptor identifies the peptide in the context of self-MHC molecule, and this is how the immune system is designed, so that we avoid unwanted and abnormal immune hyperactivation. So what actually happens in the context of T cell activation? So classically, it can describe, we have 3 signals. Signal 1 is where the T cell receptor sort of identifies the peptide in the context of self-MHC molecule. This leads to a cascade of events leading to activation of the T cell. But this alone is not enough, because otherwise we'll end up having abnormal activation. This should be combined with a second signal called signal 2 here, and this involves co-stimulatory molecules. For example, I've shown here CD28 and B7 or CD80. Also, there are a number of other co-stimulatory molecules like CD40L and CD40, PD1, PDL1. There are a few other sort of co-stimulatory molecules. So once the engagement between TCR and the MHC peptide complex happens, and they get the signal 2 in the form of co-stimulatory molecules, the T cell is now all primed to start acting. But there is yet another signal that is required, sometimes referred to as signal 3. This is in the form of IL-2 cytokine release. And IL-2 is needed for proliferation of the activated T cells. So once these T cells are activated, if they are CD8 T cells, which were stimulated by MHC1 class 1, they sort of generate perforin and granzymes, which are sort of severely pro-apoptotic enzymes. So they go and attack the cell and then lead to lysis of this particular cell. And similarly, when the CD4 T cell receives its cues from a coordinate antigen on class 2 molecule, they get activated to different subset of T cells, which include Th1, Th2, Th17, more recently Th9, and also T regulatory cells. This depends on the cytokine milieu in which they were generated. So, but how does the immune system know what is self and what is non-self? Well, I told you that MHC molecule will distinguish between self and non-self. But the tutoring of these T cells actually happens within the thymus. So as the naive T cells, also called as thymocytes, enter into the circulation, they enter into the thymus. And within the thymus, they are disciplined to understand what is self and what is not self. The first process is called positive selection. So this happens in the cortex of thymus, whereby any T cell that can identify the self-MHC molecule with low avidity is positively selected. If they are very highly avidly getting attracted to the MHC complexes, then they are destroyed. So this aspect is called positive selection. So this is trying to restrict the T cells from recognizing self-MHC. And the second aspect in this is called negative selection. So in the thymic medulla, most of the self antigens are presented on dendritic cells, and the T cells are trained to identify the self peptides on MHC molecules, and once they identify the self peptides, they are deleted or they become T regulatory cells. So the T cells that come out of the thymus are trained to, one, detect the self MHC, and two, identify the non-self peptides. This is how the immune system understands what is self and what is not self. So we now have the context of immune transplantation. So the graft is placed in the recipient. So this process is not very sort of smooth. This is associated with a lot of issues like ischemia, reperfusion, inflammation of the graft. So that leads to release of these MHC complexes, sort of released from the donor cells. So there are 2 or 3 different ways that have been described in which this allo recognition happens. So the first is called direct allo recognition, whereby the passively transported dendritic cells within the kidney tissue present the MHC complex along with the MHC peptide, which are recognized by the T cells. So you could ask why. I mean, we are meant to recognize self MHC. Why are we recognizing a foreign MHC here? So that is a question that is not well understood, but it's thought to be mimicry, cross-reactivity, and whatnot. But there's no clear clarity here. But what is important is for one sort of peptide, if there are 20 T cells that can recognize that peptide, which is a very low number in the context of billions of T cells that you have, 10 to 20%, I mean 10 to 15% of our T cells can actually recognize a foreign MHC and a foreign MHC molecule. So like 10% of your immune system is straight away geared to attack this kidney. So that's the reason why we go for induction, but that's the reason why we go for all these immunosuppressors. So this is called direct allo recognition. There is another way of allo recognition, which is called indirect recognition, whereby the sort of soluble MHC or the fragmented MHC in the system are taken up by the dendritic cells of the recipient and are presented through the normal expected path. So recently we have discovered this semi-direct recognition, allo recognition, whereby the MHC molecule of the dendritic cell from the donor is transposed onto the dendritic cell of the recipient, thereby presenting it in direct as well as indirect path. So immunosuppressives are all designed to prevent this T cell activation. So for example, the induction therapy that we give, ATG, it blocks the TCR MHC complex signaling. Calcineurins block the downward cascading of the T cell receptor following activation. Antimetabolites stop the cell cycling. Basiliximab will block the IL-2 that is needed for proliferation of the T cells. So the entire system that we are using is designed to prevent the activation of the T cells. So let's shift our focus to antibody-mediated rejection. So for example, I'm showing here hyperacute rejection, which thankfully is very rare nowadays given all the screening tests that we do before we transplant a patient. So what actually happens here? So let's have a brief look at the concept of how are antibodies formed. So the first event for the antibodies to form, the primary event here is T cell recognizing the peptide of interest. So here shown at the bottom here, the dendritic cells will prime the T helper cells, and then they get into the lymphoid follicles of the draining lymph nodes, and they get converted to T follicular helper cells. And the similar antigen is presented on follicular dendritic cells within the lymphoid follicles, whereby the B cells identify this as the protein of interest. And then with the help of the T follicular helper cells, they go through a process called somatic hypermutation and affinity maturation. This is a process whereby with each cycle, the B cell is more and more avidly binding the antigen of interest. At the end of this process, you are left with either long-lived plasma cells, short-lived plasma cells, or memory B cells, or all of them. So in the context of transplantation, we are interested in sensitization. So what sensitization is, it's a process whereby the immune system is exposed to these antigens that we wouldn't have otherwise seen. So the commonest causes or reasons for sensitization include previous transplantation with a mismatch. So thereby you have been exposed to these antigens that you are not meant to see. Or transfusion, usually the PRBC come with some hidden leukocytes. So these leukocytes carry these HLA antigens. Or pregnancy, where the mother is exposed to the HLA antigens of the fetus, which gets transmitted from the father. So the mother develops anti-HLA antibodies to father's antigens. And then these antigens, through the process that I have explained before, primes the immune system leading to HLA antibodies. So if you look at the pathogenesis of donor-specific antibodies, primarily all cells, as I said, express HLA class 1 and antigen-presenting cells express class 2. And these are recognized by the antibodies, and in the context of complement-binding antibodies leads to complement-related damage to the endothelial cells. And similarly, there are also complement non-binding antibodies, which by their FC receptors will stimulate the macrophages and neutrophils and NK cells, leading to destruction of the organ. So complement-binding antigens, antibodies are typical IgG3 and IgG1, as opposed to complement non-binding antibodies are IgG2 and IgG4. This is more theoretical because we don't have any sort of clinical tools to identify these at this point. And we keep talking about C4d staining all the time in the context of antibody deposition. This is primarily because the complement system is activated, and C4d is a breakdown product of the C4 molecule, and that gets deposited in the vicinity, and that is what we recognize as C4d staining on our biopsies. So we should not forget the most important element of antibody-mediated rejection, which is blood group compatibility. We take this for granted, but it is very important in the context, because obviously there are 4 different groups of blood groups: Group A, B, AB, and O. So Group A expresses an antigen called A antigen. Similarly, B expresses B antigen, AB expresses A and B. So by the virtue of us being exposed to microbes through our life, and these antigens are polysaccharides, so they're very similar to some of the microbial cell walls. So we develop natural antibodies against these antigens. So someone who's got Group A blood group, they will have anti-B antibodies. So that is where the issue is. And they develop, and if you were to transplant these patients, it leads to complement activation and sort of acute, hyperacute graft rejection. So this picture is just to say that the way the immune system or immune responses and antibody-mediated rejection are actually very similar to the infectious disease model. So here, when you have a first infection, you generate antibodies, usually following the activation of the B cells, leads to short-lived plasma cells, and then they produce antibodies. Once the active infection is settled, the response is settled, which you can see by day 30, but you're left with memory B cells. Okay? When you're exposed to the same antigen again, then this time the response is rather brisk, and the antibody levels sort of reach a peak level within a span of 2 to 3 days. And similarly, if you were to be transplanted for the first time in the context of de novo DSA, it takes at least a week for the immune system to recognize there is a foreign antigen here, and that's when you develop, and following onwards, you develop the de novo DSA. And that can lead to either late ABMR or chronic ABMR. So if you were to have sensitizing events like a blood transfusion, pregnancy, or a previous transplant, then at the time of transplant you already pre-formed DSA. And these can straight away lead to either hyperacute rejection, early rejection, or late rejection. So I can't conclude this talk without saying a few words about non-HLA antibodies in kidney transplantation. So these are being more increasingly recognized as extremely important. And somehow in the process of either a previous pregnancy or preeclampsia, for example, or lupus nephritis, there are certain antigens which are normally masked or exposed to the immune system. So the immune system considers them as new or neoantigens, and you develop some response to these. So, or in the context of transplantation, you may have sort of ischemia reperfusion injuries leading to sort of unmasking of certain newer antigens. And this can lead to development of antibodies called non-HLA antibodies. They're non-HLA because until recently we only know about HLA as the primary targets, but in the last 10 years to 15 years, we have also identified these non-HLA antibodies as extremely important. A number of them have been described as shown on the right panel here. The most common ones that we always are thinking of in the context of unexplained sort of antibody-mediated rejection, or 1-angiotensin-2 receptor antibodies, endothelin receptor antibodies, and MICA, are also called as MHC class 1 related gene A. So this has been shown in a large study from France recently, last year, that they're actually important in the causation of antibody-mediated rejection. The graph on the right shows if a patient were to have synergistic anti-HLA antibodies as well as MICA antibodies, their graft performance is significantly poorer compared to those who do not have it. So wrapping it up, so you have the kidney allograft cells which sort of release these MHC molecules, and they're presented to the lymph to the T cells in the lymph node, where the CD4 and CD8 cells are activated. CD8 cells cause direct injury to the tissue. CD4 T cells with the help the B cells to produce antibodies, and that lead to opsonization and subsequently injury to the graft. Thank you. Response. Okay, these are all end products, and the production of these cells depends on the inflammatory milieu that a particular patient is exposed to. So Th17 is well recognized in the context of autoimmunity,
Yes.
Primarily because this will lead to fibrosis, inflammation, and I'm certain that it is also relevant in the context of kidney transplantation.
Yes.
But as to because each patient behaves differently in the context. For example, it has been shown the response to IL-10, which is considered to be a regulatory molecule or regulator sort of cytokine. It has been shown to be beneficial in the context of kidney transplantation. So there are various biomarkers that have been involved, but the bottom line is these are all end stage where the horse has already bolted, which means the immunological insult that has to happen has already happened. And whatever you do from here on is just managing the damage rather than trying to deal with it. So I'm sure there are, I'm not very particularly familiar with this literature in terms of how the biomarkers are helpful, but that is what I would look at it as.
Yeah, I mean, there is literature coming up about this, the ratio of Th17 Tregs, and then the drugs which can probably, act at that level, probably which may have role in future as well. So another question I just wanted, see, in the past we had donor-specific transfusions. Of course, there's a relevance of, immunological perspective. Can you just explain for the benefit of the students what is the donor-specific transfusion, which we used to have in the past, but of course we're not using it now?
I think, nowadays we are using PR bases where most of the leukocytes are depleted, and an easier way is probably going for a leukocyte depleted PR basis, because the blood transfusions do carry lymphocytes, and these lymphocytes carry HLA molecules, and these HLA molecules will incite an immunological response. So I think, that is how I would look at it as.
Right, thanks, Sreera Pani. Can I open the floor for the questions? Any questions from the floor?
Related to the blood transfusion and the use of irradiated packed cell. So, if you are doing a irradiated packed cell transfusion, do you think that it is 100% proof that they do not initiate the sort of HLA antibodies? And the second one is that when you test the DSA, do you think that the detection can escape?
Yeah, I think, no method is foolproof. Leukodepleted cell PRBCs still may contain fragments of these HLA molecules which would incite an immunological response. That is probably the reason why we go to extreme pains to try and avoid blood transfusion in these patients. So that's not foolproof, first thing. And second thing is, can DSA, I think we have lectures coming on anyway on further on these DSAs as to how and what we should be doing. But certainly yes, you can miss some of these antibodies. I think we'll save this question for the next lecture.
Thanks, Sreera Pani. Dr. Santosh, yeah.
Sir, I have a question. Does antigenic load also contribute to how immune response is going to come? If you have less antigen load, if it's a very massive antigen load, is it? Do you get the same type of antibody response, or do you get a different one?
Certainly, antigen load does matter, because you need a sort of a critical load of these antigens expressed on MHC to incite the immunological response. So, for example, the TCRs, they need to come together when they're getting activated, and that depends on the availability of enough antigen for that to happen. If the antigen load is low, even though it is sensed by the T cell, the TCRs, which were meant to come closer together for the activation to happen, does not happen. So yes, it does matter.
Because we see the same trend when we go ahead for, let's say, double dual kidney transplantation, or with a liver transplantation combined with kidney.
I think the context of kidney transplant is slightly different, because there is no dearth of antigen load. Okay, there is an enormous amount of it, so I don't think that would be a huge.
Then does Madam just ask that blood transfusion from the donor,
Yeah.
Does it help out in the same scenario? If you're giving blood transfusions before transplant, are you going to increase the antigenic load so as to prevent the further antibody
I don't
response?
think I would do anything as such.
Doctor, please. Yes, doctor. Yes.
To the extent that there is a 3 to 4 log reduction with the leukodepletion, which was done at the time of preparation of components. So that means we are introducing with one unit less than 5 into 10 to the power of 6. So if we kind of, extrapolate the CMV data with this, because the CMV is inside the WBC, so some data says like the risk of CMV infection, it's as good as giving the CMV negative blood. Okay, leukodepleted blood if you give. So it is the same with the HLA, the leukocytes are there, it is with a very, very less quantity. That answers your question, where the antigen stimulus is very, very less when we give the leukoreduction. So if I kind of quote the recent studies, so the risk of developing HLA antibodies after 2 to 3 transfusions, if it is a properly leukodepleted blood, so it is only 5%, or if I can say around 3 to 5%.
Do you suggest a leukodepleted blood only to be transfused even pre-transplant?
100%, because anytime sensitization can lead
happen,
to
yes.
HLA antibodies.
Right. Thank you so much.
The
Dr.
day
Sreera
long
Pani.
is for the transplant immunology. I think don't exhaust all your questions in the first talk itself. I think you can
Thank you so much.